Good morning, everybody, and welcome back to your Lunch Break Live. My name is Ivana Harenque if you're new here, and if you're not, thank you for coming back. Today is Tuesday, August the 9th, and today we're going to talk about monkeypox. There is a lot of misinformation going around about monkeypox. There's a lot of people who also just don't have any information about monkeypox and have a lot of questions. So today we're going to talk a little bit about the virus, what exactly it is, who's at risk, talk about vaccines, and more. So today I am joined by UAB infectious disease expert, Dr. Michael Saag, and I am joined by Dr. Wesley Willeford, the medical director of disease control at the Jefferson County Department of Health. Now, gentlemen, thank you so much for joining me today to kind of get the word out on a lot of this information. You know, we were talking before we went live about how with coronavirus, there was so much information and people were generally educated on the basics of the virus. Monkeypox seems to be a little bit different. There has not been this influx of information. So Dr. Saag, I'm going to start with you. Tell us a little bit about monkeypox. Give us kind of the layman's terms of what it is, who can get it, and what do you do if you get it?
So monkeypox has been known for decades. It's not a new virus. It's been mostly in the animal kingdom in sub-Saharan Africa for the most part. We've seen it in the United States before with an associated outbreak around 2003, where some animals developed this and handlers of the animals got some cases, but it really has not spread in an epidemic kind of way as we're seeing right now. So that's what's different. It's in the family of viruses that's similar to smallpox. And that's really good news in the long run because we have eradicated smallpox for the most part around the world. Vaccines work for it. The previous vaccines have some activity against monkeypox. So if you're a person like me who was born in 1955 or before they stopped giving smallpox vaccinations around 1977 in the United States, you may have some partial immunity that is residual. But it is a new variant. It seems I'll use the COVID sort of language because it mostly monkeypox was not spread that much from human to human. It was usually animals to human, and that's what's new and different about this. But generally speaking, the other good news from smallpox is that we've worked on treatments for smallpox over the years. We have a lot of antiviral agents and a new vaccine that I'm sure we'll talk about that has activity that can help protect people. And we do know a fair amount about it. I think to your point about the general public and COVID having such a great knowledge, I would say that if we look at the exact same time frame of COVID was first described in late December 2019, the general public really didn't know that much about it into March or April of 2020. So that's 4 months. We've been about 4 months into monkeypox. So I think the general public's learning curve is similar to what we have with COVID. We've just been around COVID so long that everybody's kind of an expert by now.
An expert, probably reluctantly, right?
Exactly.
Now, it is worth saying the Alabama Department of Health did release a statement yesterday saying that as of yesterday, as of August the 8th, there were 19 confirmed cases of monkeypox across Alabama. Now, the Department of Health did say that they expect those case numbers to rise as testing increases. Dr. Willeford, what are we looking at in Jefferson County? How big of a threat is monkeypox to Jefferson County and to Alabama as a whole?
Yeah, I think the interesting thing to kind of put that all into perspective with monkeypox is really thinking about how contagious it is. So I think since we've been talking about COVID, I think that's a great place to give a basis to compare it to. You know, the typical thinking from epidemiology is that a significant exposure to COVID-19 is being with someone within 6 feet for 15 minutes or longer. For monkeypox, it's very different. So as far as transmitting it in the air, that's being within 6 feet for 3 hours or longer. So it's certainly not going to spread as quickly as COVID-19. The main way that we're going to see it spread is really going to be through that touch or touching items that have been contaminated with monkeypox virus, close intimate contact with someone who may have the monkeypox infection. That's really what's going to spread this. And so to answer the question of like kind of how big of an impact this is going to be, I don't think it's going to be on the scale of COVID-19 by any stretch of the imagination, but I do expect to to see more cases. I think that's going to almost be inevitable. How high is that going to go? Again, very hard to gauge. I know in larger states, New York, I think New York, California, Florida, there are certainly the case numbers are into the hundreds. Is it going to happen? Is that what's going to happen here in Alabama? Hard to know just yet. And a lot of that's really going to be contingent on getting these vaccinations out to people and into people's arms.
Well, and I want to talk about vaccines in a minute, but you said something, Dr. Willeford, I want to quickly touch on, and that is the threat, again, kind of location-wise here. Now, I know in the beginning when Alabama reported its first cases of monkeypox earlier this summer, they said the first 2 cases were in Mobile County and in Jefferson County. Since then, they have just provided a number and not a location. We saw during COVID, again, just to keep kind of that comparison here, that the Department of Health put out essentially a map, and literally a map, I should say, with actual case numbers and kind of a color coding system of how the counties were doing. Do you expect something like that for monkeypox, or do you think right now the state is just going to say, for privacy reasons, that there are X amount in the state?
I think for the foreseeable future, it's going to be just the X number for the state. And again, the reasoning behind that really has to do, as you alluded to, is with privacy. And as the numbers get larger, if we were to get into the hundreds or thousands, then that becomes a little bit of a different ballgame, because the idea is that you don't want to inadvertently disclose medical information about someone to the public by virtue of saying, if there's one case in, X county, and maybe it's a very small county, or it's a county where people know each other, you could potentially suss out who that person is. And so what we're trying to do is not run the chance of breaching anyone's privacy. So I think for the foreseeable future, you'll be seeing more of the total number for the state until a threshold is crossed. And that's all defined by a law. I think there's some HIPAA laws that specifically address the thresholds that have to be met before you can begin to disclose that information, and the size of the area in which that information can be disclosed.
That's interesting. Dr. Saag, I want to talk a little bit about who is at risk here. Now, we know anybody can get monkeypox, but specifically what we have been hearing about is that the LGBTQ plus community is at higher risk. Why is that?
Well, as Dr. Willeford said, this is spread mostly by close, intimate contact, skin to skin. So that would include intimacy and during sexual activity. If somebody has a lesion, a bump, it could be a small one, it could be a large one, it could be open, it could be scabbed over. It can transmit the virus. It's not until that thing is completely healed that we feel pretty confident it won't be. We didn't talk about this, but from the time of exposure to the time of getting sick is around 10 to 14 days. So that's somebody may have the beginning of it, not really know it, have sexual activity with someone, close, intimate, skin to skin exposure, and then pick it up, and then 10 to 14 days later, they develop the symptoms. So it is right now, for the most part, in the gay community, and it reminds me a little bit of the early days of HIV. The virus may start there, and that's where it is right now. But it kind of creates an illusion that it's only in the gay community, or that it cares about that. It doesn't. The virus doesn't care. It's just looking for a place to set up shop and cause an infection. And right now, because the population among especially gay men is the one that's affected, is the population affected, that's where we're seeing the cases. But I think by getting on top of this, by letting people know what the risk is, especially getting vaccines out, getting people into treatment, letting them be aware if they see bumps on their skin, they should abstain from sexual activity, get it checked out so they don't spread it to somebody else. Those are the kinds of messages we're working on right now.
Well, and you talk again about how this virus is circulating right now in the gay community. And you talk again about how this virus is spread not like COVID-19, but through skin to skin contact and direct touch and things of that nature. But Dr. Saag, I think a question that a lot of people have is that gay people aren't the only people that are having sex with each other. So why is it not spreading outside of that community?
I don't mean to be flippant, but because that's where it is right now. So it could easily spread into heterosexual community, for example, over time. And I think that's what we're trying to build a wall around the epidemic. Let the people most affected, which is right now in the gay community, be very aware of what's going on. Encourage them to monitor for this and to get vaccinated as soon as we can get the vaccines on board. That's a ramp up right now. We're not where we need to be, but it's getting a little better. And if we can contain it, then I think we can keep it under control. But if you think about it like a virus like herpes virus, that's one that's transmitted by close, intimate contact. It doesn't care if you're gay, straight, or whatever. It's you give it a chance to infect, and it will. So we're trying to get it contained. And again, it is for now mostly confined to the gay community. But to me, that's an opportunity. If we take it seriously, called a public health emergency, that's totally appropriate because it gives us the resources to bring it under control.
I think that was a good distinction you made, Dr. Saag and Dr. Willeford. You kind of alluded to this earlier as well, that this virus doesn't care if you're gay. This virus is not saying, you know what, I'm only going to infect the LGBTQ plus community. No, it's not. It doesn't think that way, right? It's just spreading in the places where it can spread, and that is the community right now. And I want to get back to that in a minute. Dr. Saag, I think that a lot of our viewers know you have been, again, on the forefront of AIDS and HIV research for a long time. So I want to get back a little bit to that. You mentioned a comparison. But Dr. Willeford, we just mentioned vaccines. Now, we know that there is a vaccine that was not developed specifically for monkeypox. It is a smallpox type vaccine. But this vaccine has been said to work against monkeypox. Tell me about that vaccine. And I'll also note the Alabama Department of Public Health said yesterday that, again, as of yesterday, they had received 1,271 doses of this Jynneos vaccine, and they expect about 4,600 more doses. So tell me about the vaccine. Who should get it? How do they get it?
Yeah, so the Jynneos vaccine, which is the one that's mainly being used right now, there's another vaccine that's available called ACAM2000. I'll talk about that one in a second, but I want to start off by talking about the Jynneos vaccine. So this is what we call a live virus vaccine. It's attenuated, meaning that it's not going to replicate like a normal virus. It's just sort of the body's going to see it, is going to act on it, it's going to build protection with much reduced risk to whoever's getting the vaccine. It's a pretty standard type of vaccination strategy to what we have with other vaccines that people get throughout their lives. This vaccine at the moment is listed as it's a 2-dose vaccine. You get the second dose about 4 weeks after your first dose. And then you're considered to really have that really strong, robust protection about 2 weeks after your last dose. And so that vaccine is available in very limited quantities, as you alluded to. You know, you think about a state the size of Alabama, I think over 5 million people. You know, that's not a lot of vaccine, of course, to go around the entirety of the state. So we really do have to focus that vaccine to people who are at the highest risk. So we're really focusing on people who may have had a recent sexually transmitted infection, someone who has actually been exposed or had a direct contact to someone with monkeypox, someone who may have had multiple sexual partners in the past 14 days. Those are the groups that we're really focusing on. In particular, members of the LGBTQ community is really what we've been trying to aim our messaging towards. Again, one of the issues we're running into is just because there's so little, I think there's more interest right now than there is vaccine. Of course, we hate to find ourselves in that position, and we're really at the mercy of the federal government trying to get more vaccine in and get more people vaccinated. The other vaccine, as I alluded to, that ACAM2000, so that's a more, it's sort of the successor of one of the original smallpox vaccines. It's made with what we call a vaccinia virus. It's the same thing, same type of virus as what's in Jynneos, but it's live, it's able to replicate. It has a higher rate of complication associated with it on average than Jynneos does. So I think it's something that people are a little bit nervous about, just because we're worried that we may have some side effects for people that we want to try to avoid if at all possible. The other thing about that ACAM2000, it's a little bit more technically challenging to give. It's not a simple injection that you put under the skin. There's a technique that we use called scarification, where essentially a wound is made on your arm. So like when you see our parents, oftentimes, they'll have, usually on their left arm, they'll have that little bump. That's where their smallpox vaccine was administered. So it's a very similar technique where you'll have a little scar that you'll carry around with you for the rest of your life with that vaccine. It only requires 1 dose, but again, a lot of the hesitation with that has been out of concern that there may be more adverse effects associated with that vaccine than with Jynneos. So that's where that's preference for Jynneos has really been put forward. So at the moment, most of these vaccines are going to be available at health departments. So at Jefferson County Department of Health, the other regional health departments across the state are going to have some availability, but again, it's still very limited, and we're really trying to screen people to see if they fall into these risk categories. And we really urge people, if you're not in these higher risk categories, now is not the time to get the vaccine. we really want to preserve it for people who are going to get the absolute most benefit out of it, and really try to stop this from spreading any further. And hopefully we would head off the need for additional vaccinations to the general public.
And again, just to be clear, the doses that Alabama has received so far are that Jynneos vaccine. Yes. They are not the scarification, I believe that you called it, that other vaccine. And you mentioned again that this, 1,271 doses of this vaccine, that does not hold a candle to the population of Alabama or the population that seems to be at risk in Alabama. So when you say that you at your county health department and at other health departments across the state are really reserving them for the most high risk patients, who exactly do you mean by that?
Yeah, so the highest risk patients in this case are going to be members of the LGBTQ community, especially if they, first priority is going to be, well, I would say first priority is going to be anyone who's been exposed to an active case of monkeypox. Those people are going to be our number one priority because that's where we can certainly get the most benefit out of it. Then the next priority is going to be members of the LGBTQ community, especially if they've had multiple sexual partners in the past 14 days, especially if they've had a recent diagnosis of a sexually transmitted infection. Those are the groups that we're really trying to focus on and really trying to get that vaccine out to. And then the last group that we've been working on are laboratory workers who work directly with monkeypox virus samples. So someone who may be working in the lab where they're processing the samples. That's the other group that we're trying to get some vaccines to.
Dr. Saag, we've talked a lot here about how this virus right now is circulating in the LGBTQ plus community. Now, again, you have done years of research and worked with AIDS and HIV patients and with those viruses. So tell me a little bit about what the worry could be with isolating monkeypox and pigeonholing it and saying, well, that can't happen to me. It can only happen to this group of people. Or the fear that, again, this is spread by skin-to-skin contact. There was a fear look back at the AIDS crisis of touching people, of hugging people, because people were worried that they could get HIV AIDS. So tell me about the worry there and what you see happening with monkeypox.
Well, if we go back to 1981 or even a little bit before, HIV in the United States was spread mostly in the gay community, especially the MSM, the men who have sex with men. And so as it released, as people learned about it, it's very similar to what we're seeing with monkeypox right now. And with that, not only came this concern among the gay community, but there was also some stigma associated with the diagnosis of AIDS. And that led to a lot of the fear of contagion of being around people with AIDS. And that was a problem that we fought through. Simultaneously, or at least a little bit later, as AIDS went forward in the sub-Saharan Africa area, which became huge, it was mostly equal numbers of men and women who were infected. So it goes back to the earlier point we made that the virus doesn't care. When we say it doesn't think, it doesn't have a brain. All it wants to do is survive and replicate. That's it. So it just has one mission in life, and you give it a chance to cause an infection, a lot of times it will. And so our job is to prevent that type of exposure. So there's a little bit of a catch-22 for us giving out messages. One is we've already talked about, we want to get to the vaccines to the people at highest risk, which right now around the world, but especially in the US, seems to be mostly men who have sex with men who have had a recent exposure or at higher risk. And inadvertently in that messaging, we're also saying to the general public, oh, well, if you're not in that group, you don't have to worry about it right now. And that's a true statement, but it does create some stigma, and it does create some maybe misinformation indirectly that the virus only or chooses to affect men who have sex with men. So hopefully by hearing this conversation, people will be a little bit more aware and have a little bit more sophisticated thinking about the messaging.
Well, and we talk again about how this is spread with that skin-to-skin contact. I have a really good question here from a viewer who says, look, if it's skin-to-skin contact, if it's touch contact, should we be worried about things like bedding, secondhand clothing, and fabrics? What would be your answer to that, Dr. Saag?
Yes, there is evidence that people who, let's say someone who had active lesions that may be weeping, they get on bedding, somebody else lays down, that virus could infect the person who's on that bed without having skin-to-skin contact. I think the efficiency of transmission is less, almost by definition, and that's common sense, but it's still possible. We worry a little bit, I'm going to emphasize a little bit, about a respiratory spread. I don't think that's going to be hardly any cases, but we theoretically know it could happen. So as a healthcare worker, if I'm seeing a patient in our clinic, I'm going to wear a mask, just like I do for COVID patients. But really, the spread is kind of the opposite of COVID. COVID's much more of a respiratory first virus. This is more of a direct contact virus. And I think we should be focused mostly on how it's transmitted in the most common ways.
Dr. Willeford, we've been talking a little bit about messaging here and about getting the word out. Now, I know that Jefferson County Department of Health, along with all other health departments across the state and across the country, and the Alabama Department of Public Health, really did an aggressive information campaign when COVID hit and when we were trying to educate people about COVID, about the vaccines and things that had to do with the virus. Does the county health department have any plans to get out more messaging about monkeypox and really get out messaging about the vaccines, who's eligible?
Most certainly. That's something that we have coming up fairly imminently. We're working on some campaigns right now that are going to be mainly digital campaigns, really trying to get these messages out to people, and certainly working with our internal PR team to get the word out about this. So yes, so we have more planned. I'm hoping to see it start coming to fruition in the next couple of weeks, hopefully sooner. It just kind of depends on getting some contracts taken care of, but that is something that we are hoping to do and really try to get word out there. Let people know what to look for, where to get vaccinated, and really the things that they need to be doing to keep themselves safe from monkeypox.
Now, we do have some questions rolling in here. So I want to get to a few before, again, you know, we're both busy men. And I want to get to a few, though, before we head out. I've got a question here, and this kind of reiterates something I believe, Dr. Saag, you said earlier. And this is about the smallpox vaccine. If you have had the smallpox vaccine, do you carry any immunity for monkeypox?
You have some immunity. Now, how complete that is going to vary. So I wouldn't count on it absolutely being protective. There are some patients who I know nationally who are in their late 50s, early 60s who have developed monkeypox, and almost by definition, they likely had a smallpox vaccination. Dr. Willeford may know more details about that. So I think if you're in a very high risk group, or if you've had a recent exposure, you should check with the health department, even if you've had a smallpox vaccination, because that would have been a long time ago, and your immunity could have waned to the point where you still might develop symptoms. Wes, what do you think?
Yeah, I think it's very possible, and I think the issue is that we just don't know. You know, how long is that protection from the smallpox vaccine really going to last? So if you have been exposed to someone with an active case of monkeypox, even if you have been vaccinated with smallpox vaccine as a child, I think there's a good chance you're still at risk, and we'd be happy to, you know, to be able to evaluate you, potentially vaccinate you, just because we just don't know how well that's going to perform over so many years.
You know, I might add that another group who have likely received smallpox vaccination are people in the military when they served overseas, especially in the Iraq and Afghanistan war effort. They were worried about biowarfare, and I think that's, at least historically, was part of the vaccine program of the Department of Defense.
Dr. Willeford, do you worry about this, again, the stigma that we've been talking about? Do you worry that people will be afraid to walk into the Jefferson County Department of Health and ask for a vaccine because they are afraid of a stigma?
Yeah, and I think that's something that we, especially some of the services that we offer, especially regarding sexual health, that's something we worry about kind of constantly, because we want people to understand that we're a resource that's here to help people in a completely neutral and helpful and friendly way. We want people to be able to walk in here and know that they're going to be taken care of with a lot of respect and be taken care of in a very caring and kind manner. And that's something that we dedicate our clinic to. And I really want to say that would extend to the monkeypox vaccine. But that being said, I do worry that the stigma is something that keeps people from seeking this sort of care, because they're worried about the reception that they will receive. And I can say without doubt that coming to the Jefferson County Department of Health, you will get the best possible care that you can. That we're gonna do everything we can to help you out.
Dr. Saag, we talk about, again, some of these transmission and how monkeypox can be transmitted. We talked about skin-to-skin contact. Do people need to be worried about hugging friends who are in the LGBTQ plus community, or say sharing a dinner table, sharing a seat, things like that?
I wouldn't be afraid of being around people who are in the LGBTQ community, because first off, we do have cases in our community, but they're small numbers of cases, number one. Number two, if someone is infected, they're going to take care of themselves, and they're not going to be out and about hanging around or going through, they're going to quarantine themselves to some degree, and nobody wants to infect somebody else with this. So at this point in time, there's such when you put everything together, I would not be afraid of having social activities with anyone for fear of contagion of monkeypox.
Dr. Willeford, how do we beat the stigma?
I think right now the best way to beat the stigma is really just by helping to explain how this virus works, and explain that, just because, as Dr. Saag alluded to, just because it started in one group does not mean that it's going to remain there, does not mean that it's going to just be there forever in perpetuity. I think, what we'll see, unfortunately, like any virus, a virus is going to do what a virus does, which is make more of itself, spread to other people, spread to other populations. And I think we'll see that this is a threat to everyone, so that it shouldn't be it should not be thought of as a threat just to people in the LGBTQ community. It should really be thought of as a threat to everyone. And I think that's the most important distinction when we're trying to alleviate stigma.
And Dr. Saag, same question to you.
Yeah, stigma is a real hurdle for us, and when you really think about stigma, a lot of that stigma is what we call internalized stigma, where somebody who's in a risk group or somebody who's affected by a certain disorder, and it's not unique to infectious diseases, feel like other people are looking at them differently because they know who they are, and they feel like people are judging them, and it affects their behavior. And a lot of that behavior that's harmful to them is the fear of going to the health department or the fear of seeking care because they don't want to out themselves as being potentially infected with, say, for example, monkeypox. So the message to everyone is let's try to throttle back stigma as best we can, be kind to other people, especially if they're not exactly like you are, and be accepting. And if you are in a group that might be more at risk, be upfront with what conditions you might have and seek help, because that'll help you, but it'll also help reduce the spread if you happen to be infected with monkeypox.
Great advice, whether we're talking about monkeypox or not. Dr. Saag, final question, Dr. Willeford. There again, 4,600 more doses expected of the Jynneos vaccine. Hopefully, Alabama will be getting. Currently, we have a little over 1,200. There is probably no doubt that there will be more people than, say, the 6,000 or the 5,000 doses. And again, if that's a 2-dose vaccine, you can do the math. There will be more people who want to be vaccinated. Do you believe that Alabama and the country will have enough doses of this vaccine to vaccinate anybody who wants to be vaccinated?
I think in time, the answer is yes. In the short term, I think there may be some logistical challenges to really getting every single person who wants to be vaccinated taken care of. I think the company that produces the Jynneos, I think it's called Bavarian Nordic, if I'm correct. I think that there are some concerns about how much scale up they're going to be able to do to meet the sort of the demand that the world is placing on them right now. So I think that there's going to be some discussions on really how to adequately stretch that vaccine supply, get as many people protected as much as possible. And I think that discussion is currently going on now at the high levels of the federal government, really trying to determine what's the best way to keep this under control. So I think over time, yes, I think everyone will be able to get vaccinated. In the short term, I think that there may be some people who want to get vaccinated who can't get vaccinated. But I'm hoping that is a temporary and solvable issue.
Dr. Saag, Dr. Willeford, thank you so much for coming on today, for explaining exactly what monkeypox is and giving us all of this great advice. Thank you so much. And again, as much as I appreciate you, hopefully one of these days I won't see you for a while to talk about infectious diseases. I think that's something we would probably all like, as much as I enjoy your company. So again, thank you so much for all of your information here. Everybody watching, thank you so much. We'll see you tomorrow.
Thank you very much.